Dental Reach, made with love for dentist by dentist. Supported by Group Pharmaceuticals. This event is sponsored by M&M Dental Associates and Pulp Dent USA.
A very warm welcome to all participants as well as our moderator, Dr. Rumpavik, our speaker for today, Dr. Prateik, as well as Dr. Roxanne, Dr. Zainab, and everybody else from the team of Dental Reach. I am Dr. Deepa Ravichandran. I am a prosthodontist with my own private practice under the helm of Dental Park in Seawoods, Navi Mumbai. So today we are going to talk about Challenge 2 of the PRONTO Activa Challenge. As many of you all know, we have already concluded Challenge 1, which was Class 5 lesions. And today we're now going to proceed to our Challenge 2, which would be Class 3 or interproximal lesions. I would like to mention here that in the last challenge, we did receive a couple of cases which had nothing to do with Class 5. And even if well done, such cases, if they do not adhere to the challenge at present, we could not consider them. So today we are gathered here to hear Dr. Prateik give us the finer nuances of interproximal lesions and aesthetic restorative dentistry combined together. And I would now like to call on our moderator, Dr. Rumpavik, to formally declare the challenge open. Over to you, ma'am.
Thank you so much, Deepa. Thank you, Rock. Thank you, Mala. Prateik, where art thou? Well, we have just completed Challenge 1 with stupendous success and look to taking Challenge 2 to the very next level. It's going to be tougher and it's going to be better. I formally declare Challenge 2 open. Give me 1 second. When I opened Challenge 1, I had a bell and I kept the bell here. So I declare Challenge 2 open. Now, in Challenge 2, as we have shared, we will only focus on the concerns and difficulties we face in doing Class 3 and other interproximal scenarios, right, in restorations. We should delve deep into what solutions do we have today that would help convert those problems to success stories And what we are looking at is long term, better clinical outcomes. I have been part of Pronto development since its conception, much before it was launched, and the market entry since 2016, and urge you all to try this product via this challenge. Any problem, any difficulty, get back to us and we will be happy to answer your clinical queries as well as scientific queries. Over to you, Deepa.
Yes. So I don't think Dr. Prateik really needs an introduction, but nevertheless, here's a brief bio on our speaker for today. So Dr. Prateik has done his BDS in 2010, and then he did not stop his education there. He went on to do his master's in oral lasers. He went on to then go ahead and do a PG certificate in oral implantology. He also has an advanced aesthetic certificate. He's the KOL for Zoomax Dental and the proctor for South Asia and Dentsply Sirona. Now, he was the first dentist from South Asia to be invited to the BioClear Learning Center in Tacoma and trained under Dr. David Clark himself. He has trained over 500 dentists in the last 4 years in the field of aesthetic dentistry, magnification, and composites. He has been a keynote speaker and pre-conference trainer in various national and international conferences. And he is the technical head and clinical consultant with Aesthetics Dental Products. A very impressive bio for a very impressive speaker. So I would now like to formally hand it over to Dr. Prateik. Dr. Prateik, the floor is yours.
Okay, let me check. Am I audible now?
Yes, sir. All good. All good.
Okay, perfect. My screen was just sharing the screen now.
Yes, sir. You can go on presentation mode.
The screen waiting.
Yes, good, sir.
Okay. Thank you so much for that introduction. Well, it is good to be back online as much as I say because I have been traveling the last week, and we have started with on-site and offline lectures now, and hopefully we someday meet in person rather than just being online. And it was a change from what was happening in the last 2 years, but yes, good to be back. And thank you, ma'am, for this opportunity, and thank you, Mala Malik, for this wonderful opportunity of sharing all the cases that I have done with this product, Pronto. I have been using the bioactive resins for over 5 years now. Start off with Activa, one of my favorite products. As you all know, I have been sharing cases with Activa, and I the only problem that I had with the material was it was not very aesthetic. It would be polished as well as composite. Composite is my first one, still remain the same, but I would have always wanted this to be as polished as composite would. And now the company has come up with a new product, Activa Pronto, which is supposedly better. It's totally light cured, and we will see how it finishes and polishes when I show you my cases. And at the end, I have a little for all of you. It will not be just cases, but a little surprise from my side too. So I am from the city of Nawabs, city of Hyderabad. On the left, you can see the Falagnuma Palace, the last remaining palace in Hyderabad now, and this was the official residence of the Nizam of Hyderabad. Now it has been built in association with Taj. Now they have a hotel there. You can actually come down and have a stay with the purest luxury in India. I can proudly say that it is one of the most wanted hotels. As you all know, Salman Khan, the Bollywood actor, his sister's marriage happened in this hotel, and that's where it started getting all the limelight. But frankly, if you actually want to feel luxury, you should reach out and have a night stay at for some time. I'll be glad. The other side, you see the other two specialties of Hyderabad, apart from Hyderabad biryani, of course, that was there in my third picture. We have the chinar on the right upper, and then halim, which is basically a mixture of meat and a lot of other ingredients, but this is exclusively available in the month of Ramzan. This was about me. Thank you for inviting me here. And I am the key opinion leader for a lot of other platforms also. I'm a key opinion leader for Dentsply Sirona, for BioClear Dental Group, and Zoomax Microscopes. So at the end, we call restoring tooth structure. Dental restoration or a dental filling is a treatment to restore the function, integrity, and morphology of missing tooth structure, results of caries or trauma, or probably whatever reason that you may think of. And it may also have replacement supporting structures by dental implants. So in a broad types, you can divide it into direct and indirect. A root canal filling is a restorative technique used in the root canal. That's what we call as root canal treatment. Point here is we should stop calling it a filling and start calling it a restoration. It's like restoring those old buildings, old monuments. They call it a restoration. They will never call it filling because of patchwork. You are no longer doing patchwork. You're not filling a space. You are restoring, and you want to restore it to as much close to originality. That's the whole idea of a restoration. If something cannot match aesthetically, if something cannot match functionally, that probably doesn't deserve to come out. And if something after all this causes a lot of concern, then again that material is not suited. With types of dental restorations, like yes, we have the biggest dilemma of when to go for direct versus when to go for indirect. But within the direct restorations, because that is what we are going to put first the first column there. Within the direct restorations, also you have silver amalgams, which are still there in the practice, and a lot of people still do use silver amalgams. So this is a retentive based restoration. It used to be it required amount of tooth structure removal. It required amount of depth to create a retentive cavity. Then you have glass ionomer which came up after amalgams, where I would call a bridge between silver amalgams and composites, because composites initially worked as good as they do now, and you had glass ionomer which were an intermediate. We will speak about all of this in detail, and then you have restrictions, which are probably the mainstay of all our practices today, and we call ourselves cosmetic dentists, aesthetic dentists, whatever you call yourself. You still want to use composite as your restoration material. Now we have another line of products which I would love to use, and they are called as bioactive resins. You have these products which are specially meant for it's like a bridge between a composite and a glass ionomer. So it's basically a resin modified, a lot of resin components and amount of glass ionomer component. But what that glass ionomer component gives us is the ability to bond to tooth structure, and that's what is more important. And we will understand why composite resins fail and why we should actually be moving towards bioactive resins and bioactive dentistry in the future. So just to understand how a paradigm is formed, and I always love to story this. A group of monkeys, and people who know me must have heard the story before from my mouth. A group of scientists keeps 5 monkeys in a cage, and in the middle they put a ladder. On top of the ladder they had bananas. So inevitably these monkeys would try to climb the ladder to grab the banana. Every time among the ladder, of the 4 monkeys were sprayed with ice cold water. And because of that, the other 4 monkeys started beating up the monkey that would want to climb the ladder. So what happens is, after some time, monkey dared to go up, regardless of the temptation, whether it was a single banana, a bunch of bananas, whether they were hungry or not. They did not, because they would feel the other 4 would start now hitting them. Now the scientists did one thing: they substituted each of the monkey by a new monkey. The first thing the new monkey did, obviously, was try to go up the ladder, and immediately the other started doing it. Now, after a point, all 5 monkeys were replaced. The fourth was up, and what was left in the group was 5 monkeys that even never received a cold shower. Remember, it was the other 4 monkeys who would expect that the cold shower to be sprayed, beating the monkey who attempted to climb the ladder. We are like, we are just following blind paths that has been set aside, or that has been dictated to us, sometimes by industry, sometimes by composite companies, sometimes by whatever. But you are like that herd. We are like that herd. We do not want to climb up the ladder, and we do not also want to see other side, because I don't know. That's how things are done around here. That's what we say. When we say this restoration has to be composite, you need to ask yourself why composite and why not AC, or why not active resin, and why not a math. There has to be a definition to everything. Dentistry ends with a Y and not the single letter Y. It is a WHY. You need to ask yourself questions. There are two things that are infinite: the universe and human stability. And I'm not so sure about the former, said Albert Einstein. And I kind of correlate what he said. So the first thing that you need to do is get your basic right. Understand what material you are dealing with and understand what substrate you are dealing with. The ABC of dentistry, as if you go into a trauma case, the ABC, airway, breathing, and circulation. Similarly, you have an ABC of dentistry where you as an operator need to understand B is the substrate, and C, which is the material that you are going to use, so that all of this come together and have the longest lasting restoration in the mouth, probably. Because that's what patient asks, don't they? Chalti kitna hai? Or kitna degi? How long will this last? You are doing something. And my friends, to practice dentistry, you need this. You need to magnify yourself, you need to magnify your vision, and you need magnification. If you are practicing dentistry without magnification, I believe you are doing substandard dentistry. Please start using magnification in your practice. Magnification does not necessarily mean scope only. You could use good quality loop and still be happy with them. Busy practice, as you tell me, is yes, scope a little more time. After some time, I don't think it takes a little more time. It is that you're working better. But any which ways, at least have some amount of magnification in your practice. A simple 3.5x loops for everyday dentistry, and once you get used to it, you could probably shift a high magnification loop. Like I said, are the two most in my practice. On the right, I just got my third loop yesterday delivered. That's a 5x prismatic loop from UVet. And I'm really happy. I've been using it yesterday and today since morning, and it has made a lot of difference to cases where I would not do the scope. Sometimes in the lower posteriors, it is difficult to manipulate the scope, and sometimes when I'm working with a lot of patients, and then I want to work faster, I would definitely want to use the loop because it is much more comfortable, easy to adapt, and the scope will now require your assistants to be trained a lot. So please buy, because anything less than 0.2 millimeters is not visible to the naked eye. You will never make out whether your enamel bevel is correct. You will never make out whether you've left some caries behind that you actually treating. You will never understand what is going wrong with what you are doing. So that is why I believe everyone should be having magnification in their practice and start using it, because it makes a lot of difference. Not just for the patient. If you look at it for yourself also, look at what happens when you shift from naked eye. And I just cannot see any doctor practicing like that. Look at what happens to his neck and to his back. Strain on the neck and the back. Just from a 4.5 or a 5 loop makes such a difference. The posture is so much more correct. The neck
Hi, sir.
posture is much better.
Dr. Pradeep, I'm
The
audible?
neck posture. Hello.
Yes, sir. I think your network is little bit fluctuating. Like, can we go back to this browser, sir? We can like, optimize it.
Okay. The problem is we have a cyclone in Hyderabad.
Okay.
So that probably is the reason for my network fluctuating. Uh, can I just log into another network and see? I have three.
No, otherwise, you can turn on your video and check, sir, because voice will be clear. No?
Okay, so my video.
Turn off. Yes, sir.
Second, I just try to go into another network. That is better.
Okay, sir.
Because up the greens here. So is this one better?
Yes, sir. I think this is better.
Okay, so let's start
Can you
my
play a
shift
lineup?
now.
So it's almost
So the
same.
problem is we are having cyclone in Hyderabad today, and that was probably the reason where I think the no, even it doesn't look good.
Yes, otherwise we can turn off the video, sir. Your audio will be clear then.
Yeah.
Yes, second pattern. You can share your screen, sir. Hello, I'm audible, sir.
Yes, I'm trying another network. 1 second. Okay, so this one looks better, shows better on my. Yes,
Yes, sir. This is better.
this is better. Okay, perfect.
Okay, sir. Thank you, sir.
Thank you. Okay, so this one hopefully is better. You can hear me better. After that little TNP break, probably back. Okay, so like I was saying, I would want everyone to start using magnification not just for the patient but also for themselves. If you are practicing with a dentistry like that, trust me, you are going to lose a lot of your years sitting at home when you are at your peak. What do I mean by that? Your practice develops over a period of time. The word of mouth develops over a period of time, and we are in a profession that gives us the best income after a period of time. So the older you are, the older in practice, I mean, the more experienced you are, the more earning you have. And at that point, if you are stuck up with back and neck problems, there's no point in doing dentistry right now. So practice with magnification, and hopefully someday you can move to a dental operating microscope, because trust me, there is nothing better in dentistry than magnification. When you can see it, you can treat it. If you cannot see anything, you cannot treat it. High magnification increases the amount of visual information to use to treat the pathology. Like I said, any open margin less than 0.2 millimeters will not be visible to the naked eye. It also helps in diagnosis better, or you can see subgingival lesions, and you have better posture, definitely. Like I said, this is picked up from an article by Dr. Carr, and you can see what happens when you just magnify a $1 bill. I think we have a similar article from Dr. Shekhar, Mahalakshmi Shekhar, and she has done it on a 100 rupee note, if I'm not wrong. So it's the same. When you magnify, you can notice so much better. You can hardly notice that these were ever visible on a dollar bill. But if you notice now, with magnification, you can see so much better. Your eyes can grasp so much better. And that's how you will be able to make out these little areas that were never visible. To the naked eye, when you look at the patient just running a probe around, I mean, that hardly helps. When you see better, you can show the patient with the microscope. Even that's a possibility. So I can click a picture in the microscope at this magnification, and I can show it to the patient. Things like these which are going wrong. The patient may have no problems clinically. Clinically, the patient might be absolutely fine, but you can always show them these and tell them that these need to be treated. Of course, magnification helps in locating your accessory canals or extra canals. Like this, the MB2 is no longer considered to be an extra canal, frankly. But yes, use of a dental loop group had more incidences of finding the MB2, and a microscope group obviously much more than a group with no magnification. I'm sure the people with no magnification also knew that an MB2 exists, but because it is not visible, how do they treat it? And that's why magnification is most important. And the next thing that you need is a good team. A good team is half your work done, because when you work under magnification, your associates need to be handing you over the instruments. you do not have enough time to make movements and then pick up instruments. So you need to train your team as well. Like I said, when you are working under magnification, it's all about handling the instrument and handing over the instrument to the assistant, and the assistant handing it over back to you. Train your team. And post COVID, I'm hopeful that all of you might agree. Practice spittoon-free dentistry. You do not want the patient to be spitting in front of you, creating aerosol vapors which may be damaging. But any which ways, even then, you shouldn't be having a spittoon in your practice. Have a high wax section and practice with a high wax section. Now, as far as any adhesive dentistry is concerned, the most important thing that you will need is isolation. Without isolation, and with isolation I mean rubber dam ideally, mostly in all your cases it should be under a rubber dam. Without isolation, there is no point in doing adhesive dentistry, because eventually there is a lot happening inside. You do not want another external force like saliva or GCF to stop the bonding that is happening. And like I said, isolation ideally gives you better retraction, better visibility, and you also have better chance of treating those lesions and the patient not disturbing you every single time. Now, it should be mandatory. If it's not, you're not doing dentistry without rubber dam in post-COVID situations. I mean, you are risking your health, risking your patient's health, and risking the assistant's health that work with you. The other thing that is important for adhesive dentistry is enamel. Please do not cut down enamel unnecessarily. Use it to your benefit. Do not cut down enamel. Stop giving crowns on teeth, cutting down enamel and putting them in the river Ganges or river Musi in my case, because I'm in Hyderabad. You do not want it to go down the drain. You call it the strongest part of the body, and if that part is down the drain, what's the point in having it any which ways? So in enamel, we absolutely trust. And lots of studies have just picked up one and showed you that a survival rate was 99% with preparations confined to enamel, and also 94% with preparations with enamel only at margin. So that's how important enamel is. You need enamel. The more you go into dentine, the more failure, the more bond failures happen. Whatever you might tell, and I will show you many articles in the forthcoming series, and you will understand that the bond ultimately fails over a period of time. Resin dentine bonds fail. And then decide what is your limit. Decide what cases can go for indirect and what cases obviously need to go for a direct restoration. Do not mix them up. Not every case is suited for direct, not every case is suited for indirect, but you will have to make your decisions based on your clinical judgment. Looking at direct restorations today, because that is my topic, you have amalgams, you have composites, you have GIC, and you have bioactive resins. GIC, as I would take it up the first, yes, the only true bond in dentistry is the bond of GIC to dentine. Everything else is a micromechanical retention. You might call it a bond, but ultimately it's just micromechanical retention. And that's why your crowns fluted with GIC still last. Because the true bond to dentine happens only with GIC. The advantages are aesthetics when you compare it with obviously amalgam, because this was an amalgam replacement initially. You have high fluoride release when you place it. The biggest problem is this fluoride release is only for a limited period of time, and slowly this fluoride falls down. And what happens is it eventually there's a lot of loss of water from the GIC, and it cracks. Then yes, it has the ability to recharge, and that's why if you have placed the GIC restoration, please recall your patient every 4 months and put a fluoride varnish on top. Now it is recharged. Now you have a GIC which is recharged, and again prevents secondary caries, or also it prevents any further tooth loss. The advantages, like I said, is bonding to dentine. The only true bond that happens in dentistry is between GIC and dentine. Then it has high flexural strength. Obviously, when you compare it with amalgam and even with composites to an extent, it has better flexural strength. The disadvantages being it is soluble in saliva. So over a period of time, you will have desiccation that happens with the GIC and saliva moving in and becoming soluble there. So now you have an open margin. Even if you put your crown, you have an open margin there over a period of time where there was supposed to be GIC cement. Then secondary caries, again, because of the possibility that it is soluble in saliva, you will have leakage, you will have biofilm formation, and over a period of time that lead to secondary caries. And then It's a semi-permanent restoration. It's not a permanent restorative material. And finally, like I said, you need to recharge it. If you want the fluoride effect, you need to recharge it. So like everything there, it's not a permanent solution. But in a short term, you have a caries prone mouth, you want to use GIC. Till before bioactive resins came, that was the only answer. You couldn't put amalgam, you couldn't put composite. GIC would be your answer to put a temporary restorative material in a cases like these, where you have a high caries risk patient. You have a patient with a lot of caries in his mouth, and you're not using bioactive resins. I'm giving you reasons of why you would shift to bioactive resins, but if you're not using them, you have GIC in your practice, please use GIC first. Make sure the patient becomes caries free before you start to restore them with composite, because ultimately composite is plastic. If you do not have a mouth that's not prone to caries, then composite will eventually fail. You will have marginal discoloration, you will have marginal leakage, and eventual failure with composites. And then with class 5 restorations, again, this would be the answer when you compare it with composite and you compare it with amalgam, but no longer. I have long time back moved to bioactive resins for my class 5, and now for the anterior class 5 you have pronto. I believe that was the first challenge you guys took. You have pronto for anterior class 5 and you all know how it works. Pediatric teeth, yes, because the patient would not sit a long time on the chair, and you would want fluoride for those patients. So quickly finish off your restorations with the GIC. Now even for that I use Activa Kids, which is white in color, just to make it more radio opaque and look the same. And it is easy to place, so I don't have the hassle of putting a lot of a bond isolating. With kids I can be faster with GIC restorative, and I can be much more faster when I'm using a bioactive resin like Activa Kids. The only answer where you might have today is a light cure resin modified GIC, not the true GIC, resin modified GIC, like a Vitribond used as a liner. But even for that, bioactive resins have come into the picture now. The whole the whole problem of using it as a liner is it does not have enough contact with the external surface to prolongedly give it the fluoride effect. So the fluoride would only be temporary. Over a period of time, the effect of the fluoride would be lost because it doesn't have the recharge capacity. Then you have amalgams, I mean, which was probably the longest lasting restoration after gold if you do it properly. We all have the patients who come in with 10 years of service, 15 years of service. Now, the biggest problem with amalgam was, yes, aesthetics. Yes, you had secondary caries, but then that was probably because the practitioner left it behind. You need a base which had to be good. Then now it is an accepted health hazard. So you will not be using amalgam anymore, especially the amalgam vapors when you take it out. The biggest problem that I feel are the last two. One, that it caused cracks onto the teeth, cracks like these. And second, it needed a retentive based cavity preparation. The problem with the retentive based cavity preparation is you need to remove, like Dr. G.V. Black said, you need to remove a minimum of 1/3 the intercuspal distance to have enough strength with the amalgam. You cannot have small amalgam restorations and expect them to last. So they would be retentive, and that my friends was the biggest flaw with amalgams, the cavity design. Just run through this, and if you understand that the two most important structures in the human mouth are, especially with the tooth, are the peripheral enamel rim, because enamel, and then the intercuspal ridges. Every time you did a class 1 amalgam restoration, you would take away these intercuspal ridges, make it a part of your restoration, and call it extension for prevention. It did not prevent anything, because now when the patient bites on this, these cusps start to flex individually. Because of this flexure, you would develop cracks along the cavity lines, and eventually you have a vertical root fracture and the tooth goes into the deathbed. But that was the biggest flaw with amalgam. Studies there suggesting that if you just take off half the intercuspal distance, you see so much of tooth structure loss. Just a class 1 with half the intercuspal distance. So extension for prevention did not prevent anything. It just made it easier to progress from one stage to the other. What do I mean? From a class 1 to a class 2 to an MOD to a root canal treated tooth to finally into the deathbed and having an implant in place. So that was the biggest problem with amalgam and the extension for prevention that it came along, because you would minimum do a 1/3 the intercuspal distance. Even on a class 1, you would lose 39% of its strength. Just a simple class 1 with 1/3 the intercuspal distance. And the moment you have a class 2 MOD, look at that. Class 2 MOD about 60%, and just with 1/3 the intercuspal distance. The moment you go further, about 70% of tooth structure lost. What's the point in doing a restoration if it cannot come back to its original function? If you are ultimately going to lose that tooth, when you have 100% of the strength, when it is intact, you lose about, sorry, that's a animation that doesn't play here. So you lose about 30% of its strength or 40% of its strength when you just do an MO, and you lose about 70% of its strength when it becomes an MOD. There's no point in doing a restoration because eventually it is going to fail. So now we move on to the next material that we have, composite. It was supposed to be the permanent problem to all our permanent solution to all our problems and the patient's problems too. Now let's just briefly understand what a composite means. A composite means two distinct materials which have been put together, and you think that they will have the properties of one. Resultant material should have the properties of both. Like jello fruit, like concrete, tooth structure. Even in a tooth structure, it's a composite. You have dentine, you have enamel, you have the DEJ, which is holding all of this together. So all of this is a composite. Like I said, it has organic resin matrix, it has filler materials, it has a coupling agent, it has plasticizers. Now the problem is the battle for that little bond. How does one single material bond to a tooth which has enamel, which has dentine, which has DEJ, and all of this needs to bond together? We call this the battle for the bond because you would ideally want this bond to happen and remain stable, not just happen immediately. This bond needs to remain stable over a period of time. That's the fight that is constantly going on between two warriors, between the warriors from your dentinal tubules and the bond over a period of time. And eventually, what happens is what is native to the tooth remains, what is external will over a period of time fail. All of these, it's not me telling you all of this. Look at this adhesive dentine interface, it's the weakest link in a composite restoration. Proteins, pathogens, and failures in the composite tooth interface. Long-term durability about dental adhesives. So the biggest problem with composite is the adhesive. It doesn't bond to the tooth, and this bonding that you are creating with the micromechanical retention doesn't last over a period of time. This was attributed to the hydrophilic nature. What does hydrophilic mean? It loves water. And what are dentinal tubules filled with? Water. So eventually, this bond that is created, so hydrophilic and hydrophobic bond that you're trying to create with the resin. A resin is a hydrophobic material. That's why you need to dry the tooth. Whereas the, the, the bond by itself is a hydrophilic bond, and over a period of time, hydrolysis happens because of collagenollytic enzymes that are there. And the answer to this came about when they said you need to add a matrix metalloproteinase inhibitor in there. So when you have an MMP inhibitor, they said this bond can last over a period of time. This water is actually the problem because it is also the solution. You cannot even over dry the tooth because otherwise the dentine collagen fibers would collapse and there would be eventually no bonding. You would want water, and it is always present within the dentinal tubules. Fluid is always flowing within the dentinal tubules. We all know about the hydrodynamic theory. And so the problem develops. These unbound monomers diffuse to the dentine barrier, and over a period of time, even matrix metalloproteinase inhibitors, after they were incorporated, couldn't help. The hybrid layer breaks. Look at what happens from grade 1 to grade 2 to grade 3 to grade 4. Slowly, over a period of time, the adhesive layer just breaks. And what this leads to, look at this. Lower of matrix metalloproteinases and carries progression and bond stability. Let me zoom that up for you. Endogenous enzymes remain entrapped within the hybrid layer during the resin infiltration process when the resin is infiltrating inside. And these also deteriorate over a period of time, leading to caries. Role of dentine metallic MMPs in caries progression and bond stability. Read this lovely paper and you understand over a period of time this bond is not stable. It fails. Now the same paper also had bioactive resins included. So this paper by Professor Lorenzo had bioactive resins included, and what it revealed was the Activa restorative group, when it was applied as a liner or a base, it revealed very low enzymatic activity in the interdiffusion layer. When I say interdiffusion, it's the area that diffuses into the dentinal tubules to create a resin bond. So the moment you use an Activa base or liner, it has fluoride, it recharges, it has fluoride, and it helps in preventing this matrix metalloproteinases from coming. Again, lack of buffering by composites promote shift to more karyogenic bacteria. What does this mean? It promotes biofilm formation around it. Around the composite, you have biofilm that develops, and biofilm eventually has karyogenic bacteria, which will lead to a higher susceptibility to secondary caries. You will have secondary caries around the composite margins. Again, another study, influence of organic acids from oral biofilm. Over a period of time, acids in the biofilm negatively impact or negatively affect the bond strength of self-etched resins also. That was the answer that is being given, that you use a self-etched adhesive to dentine, don't put your etch onto dentine, but even that disintegrates over a period of time. Then you have the biofilm challenge, and the moment you have biofilm that starts to develop here around the composite to the tooth interface, over a period of time, this will disintegrate and you have open margins. You develop open margins, you have an area which is full of bacteria which are karyogenic. Now, studies which now show that biomaterial is probably, or bioactivity is probably the answer, shows you that even though you have bioactiva in this, you still had oral biofilm develop around bioactiva also. But this were more easily disrupted by shear forces. On the activa, that means the moment you brush, the biofilm would get washed out. It would not remain. But on the composite, were more strongly attached, you could hardly remove them. You would need to either use an abrasive agent to remove it, and when you do that, you will also end up removing a lot more tooth structure. Look at that. Application of bioactive composite influenced demineralization at the dentine margins. So you did not have demineralization that happened over the dentine margins. The bonds were stronger and remained stronger over a period of time to inhibit secondary caries. You do not want a restoration to be done and then have secondary caries eventually. Like I said, we have now universal adhesives. It's the same. These are old wines in new bottles, which clearly say no technological advancements have come to overcome the challenges that were actually present. You are just now looking for better retention when you are using composite resins. Especially this happens in a mouth which is caries prone. So you have a patient who cannot maintain his oral health properly, who is not maintaining it well, and could be a multitude of reasons. And then the pH in the mouth is such that he has a caries-driven mouth. In those cases, you are probably not well off doing these restorations because eventually composites will fail, and you probably now need to look at biomimetic or bioactive materials. So you have bonding performance increased when you have bioactive materials which have a self-etch adhesive. So the material itself is the adhesive. You just need to put it inside the cavity, something like you did with GIC, and this work better. Slowly, these are being developed and they will be out very soon, hopefully. But what is present today? You have bioactive, and we call these the smart material. Initially, the name was suggested to be calling it the smart material, but now we call it bioactive resins. In general, these are two types: aesthetic, white like geomers from uh, Shofu, I believe, or some company geomers they are slightly hydrophilic, and then you have Activa, which is probably my go-to for all posterior cases if I have a caries-driven mouth. And then now you have Pronto, which is totally light cured and the first bioactive material to be completely light cured. So you have a material which is bioactive and yet have the properties of composite. It can finish and polish well. The only issues that came along with bioactive resins were the fact that they were a little yellow. So aesthetics was a concern. Now you have a material which is absolutely aesthetic, matches the tooth structure very well, and yet has the bioactivity. So it's like a win-win situation for everyone. I'm not getting into the costs here because not not someone who sells this, but frankly the costs are not very high also. You can charge enough from the patient to even take care of all your materials with bioactive resins. Then there were non-aesthetic cases where you have glass ionomers and resin modified glass ionomers. They are absolutely not aesthetic. They were white, chalky white. And That is where we move to bioactive now. Now, the entire definition reads a bioactive material is one that elicits a response at the interface of the material. That means the bonding layer, which was the biggest problem with composites, is being managed with a bioactive material. It also creates a proper composite bond or a covalent bond between the tissues and the material. What this does is you now have no area that is open. You cannot have micro leakage, and it creates a layer of apatite like material. It's not hydroxyapatite, it's an apatite like material in the presence of saliva. So it takes the fluoride from the saliva, recharges itself, and yet creates a beautiful contact and a beautiful intersection between the tooth and the resin. This is a photo that shows we should actually be focusing towards bioactive resins, because you see the amount of biofilm that is getting generated there, bacteria deep inside. This is by leaving smear behind. You do not want to do that. And then we move towards biomineralization now. What exactly is biomineralization? It's the formation of hard deposits within a living organism. So when you have this material placed onto dentine, it reacts with the dentine and creates a dentine-like material. We have biomaterials even in toothpaste now. Biomin, Novomin are the examples of biomaterials that are in that toothpaste. Can't we have a biomaterial that has been incorporated in a restorative material to have better bonding? Of course we can. We now have materials which will slowly plug the tubules from the inside. What this does, patient will never come back with sensitivity. I hardly have patients after the Activa restorations or Pronto restorations who come back with sensitivity. What this also means that you are stopping the progression of the bacteria inside. No longer are the dentine tubules open, they are occluded, and they are occluded pretty deep. It forms a natural apatite-like layer. Again, see how deep those resin tags over on period start forming. Now, if you look at failure from front to back, especially with composite resins, composites fail from inside out. That means composite fail from the bonding layer. But if you look at glass ionomers, they fail from outside in. They get desiccated, they get broken, they dissolve in saliva, but they never fail on the bond layer. Even if you say the worst possible restoration that has been placed, you will still see that that layer of GIC, which is close to dentine, is still there. They do not fail from inside out. They fail from they do not fail from inside to out. They fail from outside to in. They slowly dissolute. And now we have a material which is like a gel between these two. You have resin modified GICs, which is bioactive now. And that's where you should all start moving towards bioactive materials. The biggest advantage with Activa, of course, is the fact that it is also independent of the light cure. It is a dual cure material. With Pronto, this cannot happen. You will still need to light cure Pronto. But with Activa, the advantage that I like with the material in posterior cases, I isolate an entire quarter and finish them off flat, and then do my finishing and polishing with Activa. It is independent of the light cure. The biggest problem with light cure is there are so many variables that you have to a light cure. And then there is less degree of conversion the moment you move farther. You cannot have a degree of conversion which is as good when you place your light cure in contact with the tooth surface. Like I said, you have anterior failures that come, you have posterior failures that come. Main reasons of posterior failures or anterior failures in the first 6 years, if you look at this copy here, in the here if you see red, those are caries. If you see the gray ones, those are fractures. Then they went towards endodontic procedure, extractions, and others. But if you look what happens in the first 2 years, it is mostly fractures or endo. That means the bonding fails. Over a period of time now, when you go towards here, this can be operator errors where you've not bonded properly, where you've not isolated properly, and this happens initially. But after a 6 year period, when you see the failures, and a lot of them failed, about 70%, in that about 41%, the failure was caries. What does this mean? Like I said, around the margins, biofilm formation starts, moves inside, and that leads to all the problems. In the first year, it probably because of the operator, because of the bonding agent, because of light cure, because of not noticing micro cracks. Year 2 to 6, you have more chipping and cracking that happens. Composites are brittle. Just remember that it's a brittle material that you are placing there. It needs to bond well so that all these forces that happen because of the because of you biting, are absorbed by the tooth. You do not want gap formations like this over a period of time. Again, from year 2 to 6, the dentine fluids now continue to flow inside out, breaking the hybrid layer. That's the biggest problem. So you will now have in toto failures of composites or even partial failures of composites. And externally also you have biofilm which starts to degrade it. So what are your answers to all of this? Probably bioactive, because it is able to inhibit secondary caries, and also it maintains a seal. Bonding doesn't maintain a seal. That's where it will slowly fail. But when you see bioactive restorations, they do maintain a seal. They are creating a natural apatite-like layer. So there is no artificial layer that has been placed there. So ideally, before you do your restorative procedure or remove all the biofilms, this has happened to the best of us. It happens to all of us. So make sure you remove this oral biofilm by at least using a sandblaster. How does it affect our bonding? See, there's so much of biofilm there. If you bond onto this biofilm, nothing will stay. Your options then could be sandblaster, where you will be using 30 to 50 microns aluminum oxide if you are entirely on enamel. The problem with sandblasting is you cannot use it on dentine too much, especially intact dentine. It was always better to move to a softer product. So now you have aluminum trihydrate, which is softer than aluminum oxide, and you now have blasting that you can do. It comes off with water, it is softer, and for dentine, this is supposedly a better material because you have better bond strengths to dentine when you blast it. But for as far as enamel is concerned, do whatever but remove the biofilm. You do not want biofilm to be present because then bonding will not happen and then fail over a period of time because of the biofilm and the nature that it is very karyogenic. It has karyogenic bacteria. It's a simple procedure with the blaster, about just 30 seconds, and you have neat and clean enamel surfaces for bonding. Just 5 to 10 seconds, 30 seconds maximum per tooth, and you have such a neat and clean dentine interface or even the enamel interface that you are ready to bond to. A lot of questions that I've been asked. I'm not getting into details here, but use a sandblaster when you have enamel predominant to repair composites, to clean cement residues extraorally, to enhance bonding over your zirconia. If you look at the blaster, use it intraorally mostly, clean and remove biofilms, clean dentine and remove all post-endo traces, and please move to bioactive resins because this is the future or probably the present today. Now, if you look at bioactivity for patients, it stimulates natural remineralization. They are moisture friendly. They transport water. They are dynamic. They are not passive. So always, whenever there is saliva, they take up the fluoride from the saliva and self-recharge themselves. You have now with the applications, you have sealants, embrace varnishes. I've been using varnishes and sealants very commonly. Then you have restorative with bioactiva, and now Pronto, pulp and canal treatments which have now come, and you are using biodentine and other materials which go into the pulp on the pulp, and within the root canal you have ceramic bioceramic sealers now. Cerasil, for example, orthodontics. Hopefully, we are coming soon with bioactive applications in orthodontics and cements. So why not use a bioactive cement in your practice? I've been using the Activa cement for over a year now, and trust me, I've been very happy with the follow-ups that I'm getting. Now let's quickly look at some clinical cases, and then comes my surprise. So this is a child with rampant decay, and this is after Activa. So this was pre the Pronto era. Today you can probably use Pronto there if you want it to be slightly more aesthetic, but I think the aesthetics were reasonably good in this case. Again, look at this. A patient like that walks into your practice, putting composite onto those tooth would be absolutely detrimental. It would fail over a period of time. Look at that. When you have patients like these, patients who are seeking help to your practice, and you put uh, a composite resin there, it will fail over a period of time. It will not stay. Then, in this case, you could remove the caries, required endodontic treatment, and then post-op all the metrics, or this was the injection molding procedure where they filled up everything with bioactive, and this is a 6 month follow-up. Notice how good the gums have responded to it. Now, if you look at class 1 and class 2, probably small class 1s and pitted fissure sealants, you could look at flowable or injectable composites now. bioactive resins if the patient is a caries prone mouth, and deep class 1 restorations again, direct pulp capping or indirect pulp capping with biodentine if needed, or you could entirely fill it with a bioactive resin like Bioactiva. If you look at class 3 and class 4, to a point, the only material of choice was composite because of the shade match. But now we have changed to Pronto. It's a light cured material which is very aesthetic to use. I'll just show you a case done with Bioactiva. So pre-op, the patient, let me get back. The pre-op, the patient had class 3. As you can see, the maintenance is pretty bad on the patient, and she has a lot of these lesions all over the mouth. So we decided we wanted a bioactive composite material, but it was anterior, and I was not very keen on using Activa there. Then came Activa Pronto. Now Pronto solved a lot of these problems. You clean the caries, you can put a matrix in there. This was the dark triangle matrix from BioClear. You could put a matrix there. I would I warm all my composites, so I warm my Pronto also. Injection mold it. It's a uni-shade restoration. That's a diamond paste for final. And I almost forgot that. So on the other side, now on the same tooth, on the other side also, we put the same matrix, wedge, over mold. This is heated Pronto for you. And look at that finish. Look at how it finished and polished so well. Look at the gloss that is getting reflected there. That's how you measure polishability, and that's how the shade match happens. It is absolutely good with the chameleon effect and even the palatal finish. I think this was at follow up of a month where the palatal finish was amazing. So at the end, it's not a thank you, frankly, but I was told that I should show more cases, and I thought showing is not better. So I do not want to show off my cases, but I have a surprise for you. We will do a live demonstration on a class 3 case with Bioactiva or with Pronto right now. Do we have 15 minutes to go?
Yes, sir.
Okay, so I'm shifting to the USB now. This is directly from my microscope, so the feed might be a little slow. Just let me know if it is not very clear. Scope on करो. Is that visible there?
Yes, it's visible now, sir.
Okay. Can you take it to full screen, please? Okay, so here what we have done is we have mimicked the class 3 uh, prep here. Now, if you can see, the patient has a class 3, and let's believe that this is our patient for today. The patient has a class 3 lesion there. So the first thing that you do is first obviously excavate all the caries, and if it is very close to the pulp, you can follow the modified Hall's approach where you can leave slight caries behind, very close to the pulp right there, and you can go ahead and do the restoration now, more so because you're using a bioactive restoration. Now, when I do a class 3, say 2 millimeters is the amount of tooth structure that is missing after I do my final prep. My bevel would be another 2 millimeters. So if you can make it out, my bevel runs right from there till there. Everywhere it's a 2 millimeter, 2 to 3 millimeter bevel. And now if you notice the bevel, it is a graduation from thick to thin. So it's thicker close to the lesion, and it becomes thinner the moment we go close to enamel. Okay, so in this case, what we will be using is the BioClear HD matrix A102, because this is a distal part. People who know BioClear know that this is A102 here, and then we have a dark triangle here where I can show a dark triangle matrix. So in this, so the first step that you do is HN bond. So obviously, once you are done with your cavity prep, you can use selective etching if you like it. If you like to do the total etch method, it's up to you. Do the total etch 10 seconds on dentine and not more than 15 seconds. Sorry, not more than 10 seconds on dentine and 15 seconds on enamel. Once you have it, once you have the etchant in place, first let's put the matrix. Give me a matrix. So this is the A102 HD matrix from BioClear. Let's put it there for the class 3. Now the beauty about the matrix is it just goes so easily into the gingiva, so nicely and easily into the gingiva. And I can also just hold it behind from with my finger and go ahead and do my injection molding procedure. So we are going to injection mold today with Activa, the Pronto. And just to clean this up before, so the first thing that I would do after my cavity prep is done is use a blaster and make sure I remove all the biofilm. The biofilm has to be removed because you do not want any biofilm at the interface. After you've removed the biofilm, the next thing you do is, if you're using a selective etch, make sure you etch the bevel also. And yeah, I forgot to tell you one thing, always polish your bevel. Polish your bevel. The sequence to polishing would be, you can use a disc followed by the spirals that you get from 3M or Evoclar. Use them. Make sure the bevel is very nicely polished. Otherwise, you may have some unsupported enamel, and that will eventually lead to cracks. And you will have those white lines on your restorative surface. That's why it's always better to polish your bevels. Please always polish your bevel, be it an anterior or posterior case. Polish your bevels. The next thing that you do is take bond. Now all of this I prefer to do once I've put the matrix in place, because this also protects the adjacent tooth and I do not have the hassle of contaminating it afterwards. Here gingivally, if you feel the matrix is not holding enough, then you can put a wedge, or you can put a small wedge if you want to, but I will just go ahead and do it without the wedge here. After you put the bond, evaporate nicely. That was the universal bond from Dentsply that I was using, the prime and bond. Light cure for 10 seconds. Once you light cure it for 10 seconds, what I like to do again now is re-wet the entire complex with a drop of bond. What this does is acts like a surfactant. Now making sure this could be pure adhesive. So this is the pure adhesive from 3M, the 4th generation. This could be pure adhesive, just air dry it. Now use warmed Pronto. Now just to show you, I will show you how the warmed Pronto flows. So this is the warmed one. Look at how nicely it is flowing. Give it back in the warmer, please. And if you look at the non-warmed, this syringe is non-warmed. It's taking a lot of extrusion force, and yet, yeah, so I'm trying, yes. So if you can notice the difference between the flow, the warmed one flew better. I did not have to use a lot of extrusion force. That's why I like the warmed one for my injection molding procedure, just to make sure it flows into every space. But for the posterior, sometimes say you're doing a class 1, you would prefer the non-warmed. Now here, before I start to injection mold, just make sure that you are holding the matrix well posteriorly. Now start to injection mold. Never injection mold in thin air, always over mold against something. Once you have this in place, make sure your tip is always in the material, never above it. Otherwise, you might incorporate an air bubble, which you do not want. Come up till the top. Please take the light cure. You can just hold while your associate light cures. Light cure, please. Single restorative material, all done in one go. That's how injection molding and warming your composite or resins help. Because when you warm, you have better flow, you have better conversion, you have better polishability. There are a lot of other reasons to warm also. I will just do it from the palatal side also, just making sure that I have done enough. Now after you do this, make sure that you've covered the palatal. You have not incorporated any air bubbles, none incorporated there. Let me take this off. The matrix now comes off. Now the biggest advantage of using the matrix is you have a very nice finish here already. Look at the gloss already on the sides. I do not need to worry about I absolutely do not need to worry about the fact that that area has an oxygen inhibition. So because of the matrix being like a mylar strip, you do not have oxygen inhibition there. And second, I do not need to polish it. But in the area where there was no matrix that touched the composite surface or the pronto surface, what I like to do is use KY jelly. That's put in a syringe. Like to use KY jelly for my last cure. Please use KY jelly because otherwise this may catch a little yellow stain. So just make sure you're using KY jelly. Light cure under it for 5 seconds and you can just wash it off. Just to show the other black triangle that I told you, this is the new black triangle matrix kit and this is the black triangle probe. We put the probe in, the probe stops at green. This is an upper incisor, so we pick the large incisor matrix which is corresponding with the green, and once I put it, always remember this is a pair of matrices. A dark triangle is always a pair of matrices, not single. So you should always put two matrices there, one which holds space for the other incoming composite after you overmold this. So it will always go in like that, both these matrices in place. Now the procedure will remain the same like I do a class 3. H bond, first obviously remove the biofilm, H bond. After you bond it, you can take the material and overmold this. That's how simple this is. That's how simple BioClear makes it for me, the matrix and the injection molding procedure. Now after you are done with the injection molding, we now move to the 3 steps of the PG protocol. In these 3 steps, we follow 3 basic rules. You move from a coarse to a fine polisher. So the first thing that you would use is, if needed, you will use a 12 fluted carbide burr or a yellow banded diamond burr. So burrs and discs are the first part of the protocol, where I would just use the burr to remove the slight excess. Don't touch the tooth with a burr. You might lead to a lot of problems if you do that. Don't touch the tooth with a burr. Once you do this, just come about 0.5 mm shy. Yes, now stop. The next thing that we use is discs, coarse disc, the ones from 3M. I like the ones from 3M, Soflex discs. You also get from Cosmedent. So you can use these ones. Now for a disc, you would use it straight like this on the incisal edge only. So maintain your incisal edge. First, the moment you take out a coarse disc, it's a little more coarse, so use it on the incisal edge. And now invert the disc. Invert it inside so that this part is the non-cutting. Once you invert the disc, start using it on the facial surface now. Remember, the facial surface always is in 2 planes. It's not a uniplanar reduction, so it's always in 2 planes. So first at the cervical area. Now the biggest advantage with using a disc is it will not cause any damage to the enamel. It might just scratch the enamel, which you will eventually polish with the restoration. And also what it does is it makes sure that your resin composite is merging nicely with the tooth surface. Now move to the upper part, which is the second part. So it was in 2 planes. The first plane came out like that, and then you move to the second plane. Once you reduce the second plane, merge both of them together. So this is the first part of the PG protocol, which is finishing. So you have done with your finishing using a 12 fluted carbide or a diamond, very fine diamond. and then followed by a disc. After this, after you are sure that your finishing is done, how are you sure that your finishing is done? The easiest way is to take a articulating paper, and rub it onto the tooth. It should be smooth. It should not have burr marks visible. Look at the other tooth. It should be smooth like that till it becomes. Continue using your disc. Also, you can use it against your line angles. Maintain your part with the line angle. Create your line angles when you work against. So discs would be your first part of the PG protocol that I give you for polishing. The second part would be, now after this is done, after you've reached a stage where you are fine with this, that means you can either use a coarse or a medium disc, and if you are okay, look at how it has merged nicely. You do not have any excess areas there. The tooth has merged nicely with the Activa resin. Next step that you would like to use, I like the second is the pre-polishing step, in which I like the spirals from Evoclar Eve Twist. So in this, you first use the beige. This would be at approximately 15,000 RPM under medium to heavy pressure, and something that we call a stalling speed. That means you apply a lot of pressure so that it stops there. And after you finish, you will realize that you have a very nice, smooth finish with this. And it will merge the composite with the tooth surface very nicely. The resin, the Activa with the tooth surface will be merged up very, very nicely and very comfortably. Always work in one direction. Look how I'm lifting it always, and I'm not going to and fro. Always work in one direction, lift, come back, lift, come back, and work. Once you are done with this, the next step is, we are still in the polishing step or the pre-polishing step, and the next step is the use of the second spiral, which is giving you a more finished appearance or a more finished luster. So for the posteriors, you can stop at this. You do not need to go to the third or the final polishing step. You can stop at this if you want to, but for the anteriors, you would want a glass finish. So the final step of the PG protocol would be the use of diamond polishing paste with the buffs, or if you like the, give me a diamond paste, dashing. Butili. This is the Diashine paste. It is a diamond based paste. The first thing that you use is a goat hair brush. So if you are using diamonds, you will have to use a goat hair brush. This is a goat hair brush right here. This is manufactured from Ultradent. But if you are using aluminium oxide as your final polisher, then you will have to use a felt tip, because a goat hair brush cannot be used with aluminium oxide. If you are using Enhance as your final, that's an aluminium oxide based system. So you will move to the felt tips. Once you are done with this, the next step is using a Chemo wheel. So Diashine has this beautiful 3-step finisher with which you just need to use the paste once, don't use it again. This is made of 3 layers of cloth. Polish this again, this time at a higher pressure than the goat hair brush. Seems to be merging pretty well. Seems to be getting our polish back. We'll just wash this now. Look at how you have a nice and glossy surface there. Now the final step is using a cotton buff. This is much like what you used to do with a denture. Cotton buff and dry. You don't need anything there. Just dry cotton buff. Apply a lot of pressure. and you get that beautiful luster. You get that beautiful luster with the final cotton buff. Look at that. Look at it everywhere. Again, importance of magnification. I can look at it in little different planes and then make out that it's not polished well or polished well. I believe everyone can make out the gloss that we've got. This is the glass finish from the PG polishing protocol. So the first step is finishing, which you would do with a 12 fluted carbide burr, and or you might use a finishing burr from money that would be yellow banded, so fine burr. After this, you move to the discs, merge it with the disc, and then use the final two protocols, which will be pre-polish with the spirals and final polish with the goat hair brush and the diamond pastes. Okay, so I believe that would be it for today. Any questions that I may take? I hope you guys liked it first thing. I hope this was good.
It was an excellent presentation, Dr. Prateik. And I know I was not there in your clinic watching you actually polish your Activa, Pronto Activa, but I must say I almost felt as though I could see my own face in it.
So that was the idea of having it live rather than me showing off some cases with the steps.
Yes, yes, doctor, and I think our participants would really appreciate that, watching the procedure live and watching you demonstrate every single step in the finishing and polishing protocol. Because very often I know that this is the area where people have the most doubts. Which do you use
Yes.
first? What do you use after? And sometimes people know 75% of it. What they do not know is that last 25 as to how you achieve that glass finish. And I think, this was a very, very eye-opening lecture for almost all of us. So we have a couple of questions from the participants
Yes.
regarding the use of Pronto Activa and as well as the final nuances of class 3 restorations. So now, due to a paucity of time, we would not be able to answer all the questions by every single participant. So what we have done is we are addressing a couple of them live here, and the rest of the questions, we kindly request the participants to please post it on the Pronto group. And our mentors, Dr. Rumpa and Dr. Prateek, will definitely read them and answer them there and would guide you every step of the way over there. So now, first, I would call upon Dr. Rumpa along with Dr. Prateek to answer any of the questions that the participants will be having. And the first question is, I get a lot of cases where there is secondary decay around old fillings. And how will Pronto Activa prevent such situations?
So I believe most of it was covered during the presentation where I told you the biofilm that develops around composite doesn't develop around bioactive materials. And that is what helps over a period of time. And that is what has changed in my practice from when I moved from composite restorations to restorations being done with Pronto.
Okay. Yes, I would concur, Dr. Prateek. Rumpa ma'am, could you please add in your thoughts?
Yeah, what Prateek said is perfectly right because actually there's a slight difference in the chemistry of Activa Bioactive and Activa Pronto. So exactly what happens with Bioactive may not be exactly to the nano part true, but again, like that day in my scientific presentation I discussed this thing is still under consideration. We have given it for
Yes.
testing. So once the answer comes, we will be able to tell you 100% sure, yes, Pronto also repels biofilms as good as Activa. And Activa as such, I think Prateek will agree, it is both of us. I think for me, because I've been using it since years, it's my go-to material. I can do practically anything and everything with it. So Pronto is the chota bhai. single syringe and getting all the best parts of Activa into a single syringe has done wonders. So that's what these all challenges, the challenge 1, challenge 2 with Prateik, and of course he's the master of contacts and contours. Absolutely. Bravo Prateik, more power to you.
Thank you. Thank you.
So yeah, that would be my thoughts. That yes, for discolored, restorations that are decaying, so this kind of material that exchange ions that are able to make apatite, they kind of start healing the tooth from the bottom.
Inside out.
That's what my main layer is, my focus, you know. Top, yeah, we do a good finish polish, is looking glossy, like you said, you can see your face, yeah. So that is there, of course, but what we are interested in is the bottom also. What's happening there?
Correct, ma'am. I completely agree with
Yeah.
you. And our second question is, I think it already been partially sort of answered in Dr. Pratik's lecture itself from his demonstration, but still I would uh, address this question live. Is silicon index fabrication mandatory for class 3 restorations?
Well, like I showed you, if you're doing it with BioClear, you do not need a silicon index at all. You might have a slight excess in the palatal, which you can trim off. Nothing beyond that. But if you do not use it, it is always better to have a palatal index, because you do not want the headache of trimming palatally. You want everything to be done initially and the palatal finish to be just with the matrix or with the silicon index that you've made.
Correct, Dr. Pratik. I remember a case I had done a couple of years ago actually. It was just normal composite. And I would consider it to really be a very rookie mistake now that I look back on. I was a little overconfident. I did not make any type of palatal shelf because I felt that, oh, I have a little bit of the lingual wall and I'll be just fine. But I asked the patient to occlude in centric because I wanted a
Little break.
photograph. Yes, that's why I said rookie mistake. I wanted the patient to occlude in centric so that I could just take a photograph in occlusion of the prepared cavity and attack that thin lingual fracture. And yeah, I found myself in that position of having to sit and shape the palatal surface according to an anterior glide path, which I did. And it is very time consuming to do that.
Yes.
And so I guess either BioClear or at least a palatal index, just to make things easier for us, because we can freehand sculpt the anteriors to a large extent, but the palatal and the bite, no. This is what I feel. Rumpa ma'am, what do you feel?
Yeah, you're so right. We have all gone through this, you know. We have all been there, done that, like what you said. Yes, and slowly and steadily, then we started looking for something which makes my restoratives predictable. So, what are they? Some good matrices, some good materials. See, everybody is not born with a good artistic hands. Let's face facts.
Correct.
But these kind of little tips, what we collect from you, from me, from Prateik, from anyone else doing good work, not necessary, because we are only talking about Pronto here. But there are some real gems who are working fantastic clinical cases. So just those tips, they help us a lot. And here, focus is on the material. Why? Because it is doing a lot of things on its own where I don't have to think. And good matrices, since this challenge 2 is all about interproximals, good matrices are a must. Without it, not possible. Absolutely not.
Correct.
So
I
that would be.
So we have one more question. Are there special wedges to prevent an overhang or a black triangle scenario for a class 3 situation?
So if you are using BioClear, and the trick here is, if you have a wall that is remaining at the gingival side and your cavity is not too subgingival, then that wall is enough to give you an emergence profile. If you do not have a wall left in the cervical thread, that means you do not have emergence left, then it is always better to first create a deep margin elevation and then put a BioClear matrix in place, so that you do not land up with a dark triangle. And
Correct.
start using low profile wedges rather than using wedges which are made of wood, because wooden wedges are very tall. Once you put it in, they will create a flatter profile. You would want a posterior wedge which gives you the gulving also. That's where BioClear and Palodent, all of these come into the picture now.
Correct. And I think, Dr. Prateek, there is one other method also to do this, if I'm not mistaken. I mean, if a particular practitioner does not have BioClear system readily available with them, I think what most people have are the sectional matrices, the metal sectional
Yes,
matrices, which is there with everybody in their practice. And a lot of people invest in that because it can be used with the posterior for the ring, and it can also be used the other way around, the longitudinal way for it.
horizontally, yes.
Yes, correct. So I think what we can do is we can sort of wedge it into the dam. So when you spoke about the importance of rubber dam at the beginning of your lecture, this was one thing that went in my mind. Because yes, isolation, of course, we require that, but the rubber dam allows us to stabilize this metal matrix, and then we can
Wedges,
insert a
matrices.
wedge between the two matrices, mesial to one toe, then distal to the other, so that they're hugging each other like this, and we sort of insert a wedge internally between the two matrices, and then we can build up that wall, and then you can remove the matrice and remove the wedge and then continue. So this is also an acceptable method.
Yes, absolutely. But in this case, you will first need to create a palatal shell with your wax up,
With this,
because
yes, with the
that
silicon.
palatal shell will help you in orienting that matrix down there. So once you
Yes.
create the palatal shell, it will now help you orienting the matrix, and then you can use a wedge, making sure that there is no dark triangle that incorporates post your restoration, and also prevents bleeding from the papilla that might happen when you're trying to finish and polish it.
Correct. So, if we combine the last two questions, so the two ways to do, anterior class 3 interproximal restorations would be either we use BioClear, or we use a combination of a palatal index with
What's a good thing that happens with class 3 restorations usually is patient comes in when one of the wall is already there. You usually have a palatal wall remaining, so you don't need to send it to the lab to have an index. You can actually make an index intraoperatively, first
correct,
create an index and then start prepping, so it makes it very easy for you.
correct, correct. We just make a putty index and slice off the labial portion, and then we use only the
Yes,
palatal index. Correct. So the index can then be used with the metal matrix bands, which are already available in most practices. We just use it the other way around. We use it longitudinally, and we can just build up the bezier of the distal wall and
yes.
just proceed and then follow your finishing and polishing tips. Rumpa ma'am, is this accurate?
Absolutely, absolutely. So I was just sitting and hearing both of you and nodding my head. Absolutely, agree 200%. Yes,
That's really nice to hear.
absolutely.
So we are done with our questions for today's live session. As I mentioned earlier, the other questions I kindly request the participants to note it down in the group, and we will definitely answer them over there. I now call upon the MD of MN Dental Associates, Mrs. Mala Malik, to give her vote of thanks, an overview of what the next couple of weeks is going to be like in our challenge 2 using the PRONTO Activa material, as well as to give her vote of thanks. Just a gentle reminder to all the participants that only PRONTO Activa material is to be used in this challenge. No other material will be considered. Only class 3 interproximal restorations will be considered in this challenge, and no other type of restorative procedure will be considered.
I
Over
have
to
a
you, Mrs.
question from the
Mala.
audience point of view.
Yes, ma'am.
Okay, now is it only, of course, I'm good, Mala is also here, is good. My question is, this is from the audience, okay? Suppose I want to participate as a challenger. Is it only restricted to anterior class 3, or we can do a 5-6 or 4-5 interproximals? How is it going to go? So if you could give a detailed description regarding exact what cases should we post as challenges. This
So
I'm
we
talking on behalf
we
of
will we will
challenges.
come up with a class 2 challenge hopefully very soon, and then we will include your 4, 6, and posteriors in the class too.
So this is only anteriors, right?
For the
Yes,
anterior, yes.
Oh, okay, done. That was
yes,
my question.
yes, ma'am. Because
I
when
hope I
we
answered that for Mala.
Oh, perfect.
because when we consider interproximal lesions in the posterior, ma'am, the again starts coming into play, and there is all it becomes an MOD. You know, it could be an MOD or it could be a class 2, as Dr. Prateik said. So you know that would go into a whole different category altogether.
Thank
Over to you,
you
Dr. Malak.
to all our lovely doctors here today. Firstly, let me just say a very good evening to all the participants that have taken this hour out of their practice to be with us today. I think on behalf of all of you, a special vote of thanks to these three lovely, lovely doctors that have taken us through this 1 hour. I am sure all people in attendance today are going to take home tricks, tips, procedures that they can start using as of this evening. Dr. Prateek, I have one word for you. Wow. You know, I must say we do these sessions at the start of every challenge because I understand the audience is at a place where I don't know what this material is all about. And before I give out the samples and we proceed to the challenge, I need to take them on this zipping 1 hour to I am now confident of trying this material out. And that by no means is a small act to do. And I am confident that we are pretty much there. Something about Dr. Prateek, and I must share this very informally with all of you. We've been in touch for a couple of years, and I am 100% sure if there is any product, any nuance in the dental industry that says new age or that is slapped on with any kind of excellence, it does not miss Dr. Prateek's eye. It doesn't end there. What I find really inspiring, besides all his degrees or his learnings or his excellent lectures, I find it very inspiring that a doctor can be so open-minded to say, I want to try it. And then be so true and come back with every kind of issue that he has, finds a solution. You know, when we look for somebody to come and pick you on this lovely 1 hour zipping journey, I think this is what we are looking at. Dr. Prateek has been in touch with using Activa for at least 4 years now, 4 to 5 years. He has smoothly moved on to using Pronto. And today, when we wanted to see, okay, the class 3s have their own challenges. He is the BioClear man. I would say my go-to person also for matrices or any kind of questions we as a company, get on what to do when you're using matrices. I go to him. So I thought today was a very, very fitting time to get him on this podium and for us to take this journey. Thank you so very much, Dr. Prateek. I don't need to say any more besides I am so happy with how this session has gone today. Thank you, Dr. Deepa. It is wonderful having a prosthodontist as part of the Dental Reach team. All the questions that you answered and all the discussions we had here would not have been possible by someone like me. Dr. Rumpa.
Yes, thank you so much.
You have been the bedrock for this entire season. You represent Pulpdent, who has come out with this product. You have been part of the culmination of Pronto into the worldwide market. And thank you so much for supporting us all through this challenging series. Seeing is believing. Dr. Prateek has clearly shown us today with the microscope as well a complete how-to on Pronto. Now we have moved from seeing is believing because we have cleared quite a few of your doubts. Any further doubts that you might have, Team Dental Reach, Team M&M Dental Associates, our mentors, Dr. Prateek himself, Dr. Rumpa, even Dr. Preeti and Dr. Nikhil Bahupuna will be standby to answer and give their perspective on any questions you might have. Please feel absolutely free to put those down in the comments box, not just today, anytime you view this live presentation and through the 8 weeks journey that we are going to go through. I must also take this time as we celebrate our 21st year to say we've had a series of firsts this year, our 25th year. We decided to introduce PRONTO. It's the world's first mineral enriched composite. We decided to introduce it in India via a challenger series. Again, I think the world's first in how to introduce this product. We believe it not just in seeing, talking, but also in doing. It's a very, very interesting journey that we take of a good 8 weeks where we work on the product with you. This brings me, before I close today's session, to what next? What are we going to do in these 8 weeks? I just want to give you guys a quick overview. Of course, any other questions, like I said, will be answered on the group itself. So firstly, we will be putting out a link. The link will help you register as a challenger. There are certain conditions of challengers. A, you should be a practitioner. B, you should be comfortable with using composites. And C, you should be committed to putting out a case. If you're not able to put out a case, my suggestion is please do not enter the challenger series. You can very well be a member of the Pronto Aesthetic Challenger group and go through everything that goes through with the group. There is enough and more that's happening for each one of us and lots of take home. So don't worry, you're not missing out on too much. What I definitely need for the challenger is to have a deep sense of commitment to this program, because we have it too. Yeah. So initially, the 1 week will go in our selecting about 50 to 60 challengers. All of these challengers will receive samples from M&M Dental Associates. This entire process, 1 week of getting all the registrations till the 3rd of October. Thereafter, 1 week for us to send out the samples will be the initial 2-week time that we take to set the protocols in place. We then have 3 to 4 weeks that is given to you to work on the product. All through these 4 weeks plus 2 initial weeks, there is enough information that will be put out on the product, on the procedures, various angles on how you can look at class 3s from various doctors across the world. You can take 1 week of sprucing up your cases so that you have a valid presentation to give out, and then the last week of evaluation. So we're looking at 8 weeks from now of serious commitment and action. I don't need too much of your time, but as you do your case, please post it, and then we use just the last bit of time to spruce it up. We have scheduled the award ceremony for the 20th of November. So we have enough time calmly to do the best that we can, and I urge you to put your best foot forward. We work very hard back end to get all of this with you. As you can see, there's an expert panel. There is a level of excellence that we're really trying to reach at, and we would want you to feel it, and we would want you to respect it. We would want you to walk this journey with us. Thank you so much. Very good evening again. Have a lovely week, and we shall see all of you on the group, the Pronto Aesthetic Challenge group. It's a closed group. In the closed group, it's very personal and very protected. So I shall see you there. Very good evening. Thank you so much. Thank you, everyone. Bye-bye.